Good afternoon, everyone. My name is Dr. Jodie Guest. I am professor and vice chair of the Department of Epidemiology at Rollins School of Public Health and an infectious disease epidemiologist. I've been leading Emory's COVID-19 outbreak response team since the pandemic began, and I'm the host for Emory's COVID-19 videos, where we bring you the latest information about the pandemic. Today, I'm really excited to be joined by Dr. Wilbur Lam. Dr. Lam is a professor and W. Paul Bowers Research Chair in the Department of Pediatrics and the Wallace H. Coulter Department of Biomedical Engineering at Emory University and Georgia Tech. Those are a lot of names to make sure we get right. Dr. Lam serves as the Chief Innovation Officer of Children's Healthcare of Atlanta Pediatric Technology Center and is a member of the Discovery and Developmental Therapeutics Research Program at Winship Cancer Institute. He is also a fellow in the American Institute for Medical and Biological Engineering and an inductee of the American Society for Clinical Investigation. Good afternoon, Dr. Lam, and thank you so much for joining me today.
Thanks for having me, Dr. Guest.
I'm really excited to talk about the incredible work that you and your team have been doing for the last 2 years. To put this into some context, the average number of reported cases of COVID-19 in the US per day remains at its lowest level since last summer. Still, the prevalence of at-home tests, which often go unreported in official tallies, suggests that current volume of cases is likely an undercount of what is actually going on. And we've always known that testing is an underestimate of the actual number of cases we have in the United States and across the world. It's important to note that while our cases are currently the lowest they've been in almost a year, they are again rising for most of the United States and have been rising since the peak that we saw in January. This is the first time they've been rising since that time. Cases have increased in a majority of the states in the past 2 weeks, with the sharpest inclines in the Northeast and the Midwest. In Michigan and New Hampshire, for example, cases have more than doubled just since the start of April. Experts believe that two subvariants, BA.4 and BA.5, may be contributing to this growth. They are both evolved from BA.2, which is a subvariant of the Omicron variant strain that we've been talking a lot about since the end of last year. When the pandemic began 2 years ago, the United States faced an acute shortage of COVID-19 tests, and this began right at the beginning of the pandemic. Not having tests was really, most experts believe, the very first major pandemic failure that we saw, allowing the virus to spread across the country because we did not have tests to help us find out who had it and how to stop it. This pandemic has been a case study in many, many different things, but one of them would be the importance of diagnostics, which Dr. Lam is here to talk with us about today. Our first line of defense needs to be to know who has something early and fast so we can do something to prevent transmission. So over the last 2 years, Dr. Lam, you and a group of researchers at Emory Children's Healthcare of Atlanta and Georgia Tech were selected to lead the national effort in test validation and verification as one of the 5 NIH-funded point-of-care technology centers in the nation. And this is called the Rapid Acceleration of Diagnostics Programs, or what we know it as RADx, with more than $64 million in NIH funding to support the work that you all have been doing the past 2 years. This program was designed to help COVID test developers quickly refine, commercialize, and scale up their products. Such a need that we have had. So Dr. Lam, you did have a center that had just begun 1 year prior to the pandemic, and then you were given this opportunity to really help the nation and the world with testing. How did you find yourself in this role?
Yeah, it was kind of thrust upon us, Jodie. So as you said, we were already one of the 5 point-of-care technology center that's part of the NIH's POCTERN, so the Point of Care Technologies Research Network. So our center, based at Emory, Georgia Tech, and Children's, was really focused on technologies. So our center is called the Atlanta Center for Microsystems Engineered Point of Care Technologies. So microsystems is really what we were focused on. So things that were enabled by the smartphone, things that had a microchip, things that have something called microfluidics that were really meant for point of care and ideally even home-based setting. And we really weren't focused on different diseases. So because of our technology bent and because we have big patient populations and the adult side at Emory, a very large pediatric population at Children's. When the pandemic started, the leadership of the NIH realized that we here in Atlanta were the perfect and ideal center to be the National Test Verification Center for RADx. And what we've been doing since the pandemic is really serving as the eyes and hands, so to speak, for the NIH, but also more recently, the FDA as well.
That is a big lift and a big ask. And I think most people describe what you and your team have been doing is testing the tests. So tell us what that really means. How does one go about determining if a COVID-19 test is going to work well just in finding the virus?
Right. So once we were given this charge, that was really our big question. Well, how do we do this? And we were really fortunate to be able to amass a very large team. So we have over 150 people that are involved in our center at all three of our institutions now. So we do this several ways. So when a test comes to us for testing, we collect patient samples. So we do this at numerous outposts, and we've been very lucky to been doing this since the pandemic. So even when standard testing wasn't available yet, Dr. Guest, we had community outposts where we were constantly collecting samples for standard PCR testing, and we would get another sample to test the test at hand. So we were already serving the local community quite a bit of public good, and we're allowing for free testing, and we would collect those samples. So we'd be able to do that, and that allows apples to apples comparison because you're dealing with the same patient, you're dealing with even the duplicate sample, and all at that specific test. And so that's one way, our community collection sites. And we also have collection sites at our hospitals and our clinics and so forth. So we can get samples from ill patients, critically ill patients, people who are just being screened, who are symptomatic or maybe not asymptomatic. So those are clinical collection sites there. And then we have our pathology groups that are constantly collecting samples, amassing a very large biobank. In fact, we have the largest COVID-19 biobank in the country. So we collect our own samples from our collection sites, but RADx also sends samples from all over the country, sometimes even the rest of the world, to us so that we have a centralized biobank. So we have every variant, we have every subvariant, and we also leverage our DNA sequencing capabilities by our multiple scientists here at Emory who can then characterize those samples when they come in. So there's the biobank aspect, and then there's our more basic science aspect where we have our biosafety level 3 laboratory bring in live virus. We grow up all the variants of concern, and we have the capability to culture these viruses to have therefore different controlled concentrations of virus. And we find that to be a very nice resource so that we can really determine what's called the limit of detection of each test. We bring them into our BSL-3 laboratories. And then in collaboration with our folks at Georgia Tech, we can do technology readiness level assessment. So just because something works may or may not mean that it's actually ready, may or may not mean that it is ready to hit the shelves. So that's one aspect that we do over at Georgia Tech. Our colleagues at Georgia Tech also do usability analysis. So we have a human factors group that also answers the question, okay, just because it works, if it's intended to be used at home, well, how complex is it? You know, could my mother use it? Could my elderly aunt use it? Could someone who has disabilities use it? That's another major component of assessment. So we do all of that kind of together, our multiple infrastructures that we kind of all tie in together when we are doing this whole concept of testing the tests, as you said.
So we were lucky enough, my outbreak response team and I, to work with RADx and take a bunch of the tests that you had found could find the virus out into the field. And so we were a site for you where we would do regular routine testing that we know worked with people who came and needed to be tested, but we would also offer the opportunity for them to try out additional tests. and then you would pair them together. But it was really interesting watching some of the different types of tests we did. A bunch of saliva tests. We determined a couple of them didn't sit well. You couldn't put them back on the table. So then there were some crafted little test tube holders that we had, and watching people put those things together. It was a bit of a science experiment that we would have going on at the end of our testing sites. But it was really exciting to participate in that with you. About how many tests did you all find did not work well for the public?
Yeah, that's a really great question. And kind of by design, RADx knew that most of the tests wouldn't make it all the way past the finish line. We really were thinking that this would be like a funnel, an inverted funnel. And that really comes from the industry perspective. We were thinking almost like a venture capitalist, where we know that there's many projects and only a few will really make it all the way. And that's pretty much what happened. So our goal in the beginning of the pandemic was really to have 2 or 3 tests, especially home tests, make it past FDA emergency use authorization. And that really panned out. So how many didn't make it? So we've seen over 100 technologies now. But we've also helped about 15 technologies get their EUA, and we work in conjunction with the FDA on this. So that's not a bad ratio, but certainly the majority were not ready. Now, many of them are still being worked out by the technology developer, and several of them are looking maybe after COVID-19, maybe they're pivoting to another disease. Maybe they're working with COVID-19 and trying to incorporate another type of infectious disease diagnostic as well, what's called multiplexing. So there's, just because those technologies didn't make it doesn't mean that we won't see them in the near future.
And when we would provide feedback and say, this test doesn't stand up well, it tips over often, the container to put all the little saliva tubes in is too complicated, you fed that back to the developers, correct, to help them produce an update?
Absolutely. So our feedback is always taken seriously because of your group and our group, or multiple other groups within our center, where we've seen a lot of these. So our experience and know-how just the last couple of years, we've really amassed quite a bit. And the technology developers know that, the NIH and FDA know that. So when we report back our data and our observations, we've had many technology developers turn around and give us a new version within weeks, and as short as several weeks. And for example, if it's as easy as changing the instructions for use, which is pretty important, they could easily do that. And they have done that. And some of these tests that now are reaching millions of people have modified either their instructions or their form factor of the device, or even some key aspects. They're all based on the feedback your group is given within our center, as well as the other groups from our center.
I think it's so important for everyone to recognize how much work goes into every single one of those tests. And it's not just about detecting the virus, but a lot of it won't work if you can't use it. And the instructions are too complicated to be able to use consistently and appropriately at home. So Elim was the first rapid at-home test that worked against the original strain, the ancestral strain. And then all of a sudden we had our first mutation. So Alpha came and joined the game with COVID-19. What did that do to that first rapid test for you all?
Yeah, it's a really interesting question. To some extent, once we got the first authorizations for these rapid tests, we thought we were done. And then these variants popped up. So what that meant was we had to actually repeat. So we had to go back. And so what RADx did was form something called the Variant Task Force, which our center is intimately part of. And that is a joint effort between the NIH, our center, the FDA, CDC to some extent as well, where we're constantly watching, which variants are popping up. And then we get samples. We bring them into our biorepository, we grow them up in our BSL-3 laboratory, we retest. And that's what we've been doing with every variant of concern that's been popping up. what we're doing now is trying to become a little bit more proactive. So Dr. Eric Ortland in biochemistry here in our School of Medicine is developing a novel assay in which, if we know the sequence of the variant, could even be a hypothetical variant, and we know which antibodies the rapid tests use, we could then predict whether there might be a mismatch. We could predict whether or not that specific test could miss that variant at hand. So we're brute force testing, but we're also doing more prediction with state-of-the-art technology as well now.
It's nice to think that we could get ahead of this virus, at some point with that kind of work. There's been a lot of conversation on social media and in the news about every time we see a new variant, how is that variant different? How's the transmissibility different? The signs, the symptoms, the severity of disease, how well does it work against the vaccine? But there's always also a conversation about, will these tests still work? And so we really saw that conversation pretty heavily with Delta and then again with Omicron. So now we have two subvariants, additional new subvariants of Omicron, so BA.4, BA.5. It does appear that rapid tests all the way through BA.2 worked really very well against all these viruses, and we're about 80% picking up cases compared to confirmed PCR tests. What do you think about these new subvariants with BA.2? Will we continue to see these rapid tests work well, or is there too much mutation going on in these new subvariants?
Yeah, well, so far, at least with BA.2, our experimental empirical work has shown that the tests on the market, the ones that have authorization, seem to be okay. And also our predictive modeling seems to predict, or at least indicate, that with BA.2, the tests at hand that are on the market right now seem to be okay. Now, what that means for other ones, we'll just have to see, BA.4, BA.5, we're now collecting those samples as well.
Okay. I think it's important for everyone to always remember there's no such thing as a perfect test. All tests have places that they can miss things. Even our PCR gold standard is not any level of perfection. So let's talk about rapid tests and when they really should be used and when they shouldn't, because I think there is a lot of concern about misusing them as a pass to say I don't have something, and then and making sure that we're not overestimating or even underestimating how well they work. So when rapid tests miss a case that could be confirmed by PCR, is that typically because we've tested too early and because the viral load level is too low in the person who's being tested?
Yeah, it's a great question. So typically, like you said, a PCR test is probably able to detect the virus at a lower viral load than an antigen test. Now, that said, it really depends on what the context is and how you use it. So PCR testing, it's fairly involved. Yes, there are point of care PCR tests, but the rapid tests are so much readily more available. You can then do serial testing. And if you do serial testing where you test yourself on your first day of symptoms or second day, third day, fourth day, that does tend to mitigate the aspects of decreased sensitivity compared to PCR. So really taking everything into context in terms of what the test can and can't do compared to the gold standard and what the gold standard can and can't do. Now, the one thing about the rapid tests that I tell my patients all the time, and even my family members, is while there might be slightly decreased sensitivity compared to PCR tests, in general, all of the rapid tests have a very good specificity. So what I often tell my patients is, if you're positive on a rapid test, you're positive. So really, that's a good take-home message. I think that's somewhat easier to message than other more nuanced facts during the pandemic.
I would agree with that. And I always think it's important to remember that a lot of the rapid home tests, the antigen tests, are packaged to a test kit, and that is on purpose. That's on purpose so that you will sequence them. Was your group part of thinking through that as well?
Yeah. So being able to do serial testing was something our group was involved with, trying to do multiple days and really trying to see how things evolve. one question that had popped up during Omicron, especially in social media just a few months ago, was people started testing different parts of their body. They started swabbing their throat. And what the FDA and NIH asked us to do is, could you do an experiment here? Could we actually, as we enroll our test subjects, could we swab them in different places and really answer the question, where is Omicron? Is it in the throat? Is it in the nose? Is it in the saliva? And that's what we did for about 60 to 80 test subjects, and then tested some of these subjects over time as well. So at least with that small cohort, what we found was that Omicron is kind of everywhere and there's no real pattern. It goes from one place to another. And in general, it doesn't seem like the throat was any better of a place to swab than the nose. And therefore, our advice would be really follow the instructions for use. If it's authorized for a nasal swab, that's what you should be using and not a throat swab, because there hasn't been any established data for those different test anatomic sites.
So early in the pandemic, I was part of a study where we were doing at-home testing that we were video monitoring, and we did nasal swabs, we did saliva samples, and we did self-throat swabs. And we did find that people enjoyed that the least, and were least likely to get a sample that we could actually use. It is hard to swab yourself in the back of your throat, and to do so in a way that will be effective, if that would be the best place to use it.
Yeah, absolutely. And as a pediatrician, we also know that can have some adverse side effects, meaning you can cause some major puking and tantrums right afterwards.
Yeah, probably for adults too.
Exactly. I when I swabbed myself, I was not very happy about that. So.
Right. I mean, it's hard enough to consistently do the swabs, and we're also happy we're not doing the nasopharyngeal swabs anymore routinely. So those were also very hard to get done by yourself at home. Very quickly, let's talk about rapid tests and how they may see a difference in those who are vaccinated or symptomatic versus those who are asymptomatic. Does the vaccine help keep the viral load level down low enough that it may be harder to find an infection with a rapid antigen test?
Yeah, it's a very good question, and that's another experiment that we're currently conducting right now. So we're literally right now looking at all of our data we've collected here at Emory, and we're looking at vaccination status and even the timing of when the vaccination or booster was received compared to the viral load we get with the PCR, compared to quantitative antigen testing, and then compared to several of the rapid tests that we can get over the counter, really trying to answer that question. Because in theory, it might affect whether or not there's enough virus produced in your nose based on vaccination rate. One could envision how someone who's vaccinated has a pretty robust immune response and is getting rid of that virus so that you can't even really swab enough to yield a positive test on a rapid test.
All good news for how well the vaccines are still,
right.
Work for sure.
Absolutely.
You do have a new opening of a building in RADx Center that is coming. And so that's at Executive Park for those who are watching and are in Atlanta, right across the street from the hospital that's in your background. So I understand that you are looking for both adults and children showing symptoms of COVID-19 to participate in the study to test more COVID-19 tests. Can you tell us who's eligible to come visit your new center?
Yeah, so the whole goal here is to allow our community families to get access to testing easier and to do it all at once, do it for free, and also be, if they're willing, be test subjects to test new technologies. So by definition, we chose a place that was very close to the Children's Hospital, but also close to Emory. And it really is a one-stop shop for entire families. So our Children's Healthcare of Atlanta clinical team will take care of the kids, and our Emory team will take care of the adults. And that's one major reason we want to do this. We also are centralizing all of our resources so we can be more nimble and also allow us to test technologies that are very different, maybe even technologies that are meant in the clinical laboratory, but have some novel aspect to them and might not even be a PCR test, might not even be a rapid test. So having that capability to be nimble and really prepare for the next type of pandemic, and also use this place to look for and assess point of care diagnostics for other diseases. So having this infrastructure there allows us to do all that.
So if I had symptoms of COVID-19, which right now in Atlanta is easy to confuse with a lot of allergies, as we have our great pollinating season happening, I show up at the RADx Center on Executive Park, and then what happens? What else do I need to do to be eligible to participate?
You can just show up, and if you want, you can even let us know ahead of time. So if you go to acmepoct.org, there's actually a portal that you can sign up on, and it gives you all the relevant information that you need, so we can make it as seamless as possible. And if you have symptoms, we could take you. If you have no symptoms, we can take you. We have tents, and we even have a clinic space. So we're trying to put everything together under one roof.
Right. So that is a place to go for routine testing, and then to support new tests as they come available, which is really a phenomenal way to get the community involved in making sure that we're all part of slowing down the spread of this pandemic, and perhaps even preventing or helping us prepare for another one.
Exactly.
So let us turn to the future of at-home tests. I think that we've all gotten very used to them, and they are more accessible than they were previously. We still need to continue to make sure everyone has access to them. How can the tests be improved, and what do you think might be coming? There's some talk of breath tests. I know that is under investigation. Where might we be going with rapid at-home tests?
Yeah. So I think rapid tests are here to stay, and not just for COVID-19. So in the short term, a lot of the RADx technologies, the developers are trying to multiplex, where they're combining COVID-19 with another respiratory illness, one that is very common. So for example, influenza A and B, and there's some companies that are even combining RSV, which is a very important virus for populations that I see in the pediatric side, and especially those with chronic illnesses. So that's one aspect, is kind of combining of tests. And then there's new technologies that are coming. Like you said, the first breath test just got authorized, and we've certainly seen a good number of breath tests come through RADx. Whether or not that will work really depends on the setting in which it's implemented, and also not only how sensitive it is, but how specific it is as well. So there's the kind of devil's in the details in terms of how well the breath test will work, but that's certainly coming around the corner. And then new technologies that are even beyond that for other diseases as well. So I think what the pandemic has really shown us is that point of care and home-based testing is here to stay, and will only ramp up. There's starting to be this blurring of medical diagnostics with consumer products. And we here at Emory will play a major role there. In fact, we're starting a new diagnostic center that will really take all of the best of what we've done for RADx, but help our local technology developers here within our own Atlanta ecosystem really help them accelerate their technology through the translational pipeline. So that's something we're really excited about, and I think would be good not only for our institutions, but our local community as well.
Wow, the work you all have done is amazing. I do want to bring a little bit of levity to this. I read that some of your labs, or your freezers in your BSL-3 lab have names.
Indeed. We try and insert humor where we can, but certainly the freezers right now, and we got a good number of them, were all named after the characters in the show Schitt's Creek, and I think we've now exhausted that entire cast, so we probably have to bring in some other shows now as well when we get new freezers.
I love that. I was very entertained when I read that, and we do have to find humor in living through,
Absolutely.
a pandemic. Yeah.
Absolutely.
So, Dr. Lam, I just really want to thank you for joining me today, and your more than 150 colleagues who have accelerated the development of tests and new tests, and have surely saved many lives during this pandemic. The director, I want to take a quote. The director of the NIH's National Institute of Biomedical Imaging and Bioengineering called your team's work absolutely heroic. What more could you want to have said about the work that you're doing at a time when you can actually save lives? So I think it's fair to say that your work provides a model that could help us be better prepared for future pandemics. Hopefully we won't be living through another one like COVID-19, but we do want to be prepared for one. And certainly you've helped us understand that this is also helping usher in a new era of at-home diagnoses for all kinds of diseases. So your work is incredibly important. It's been a pleasure to speak with you today. Thank you for all that you and your team have done for us.
Yeah, thank you, Dr. Guest, for having me. And none of this could be done without having a great team. So, even your group was a great part of our team. Dr. Greg Martin and Dr. Oliver Brand at Emory and Georgia Tech, respectively, have been great partners who are also both principal investigators of our entire center. Julie Sullivan and Morgan Greenleaf, who really direct all operations on our entire center and working with the variants. So there's just so much of this is a true team effort that I think really attests to what we here at Emory are really good at. We've been able to really put together some amazing teams who are able to focus on a singular mission. And I think that's something that many other institutions couldn't really do. And we often get remarks on that in a very positive way. How did you all at Emory do that? And I think it's because we do have this culture that allows us to all collaborate and work together under a single task and mission. So thank you, Jodie, for having me.
Absolutely. And thank you for all that you've done. And the way you talk about Emory, I do agree. What an incredibly special place to work, and really proud of all the work that our entire community has done during this pandemic. Thank you so much, Dr. Lam, and thank you everyone for watching us today.